Hello and a very warm welcome to all of you to this trauma management series, episode 3, which is blunt trauma chest. I'm Dr. Dheeraj Nair, consultant emergency medicine, Max Hospital, Vaishali. Chest trauma is the second leading cause of death due to trauma after head injuries, and majority of thoracic trauma patients reaching emergency department are one of the most important group of salvageable patients. That means if you identify these injuries and intervene at the right time, we can save the lives of these patients. It can be clubbed as deadly dozen, which includes airway obstruction, tension pneumothorax, open pneumothorax, a massive hemothorax, flail chest, pericardial tamponade, ruptured aortic arch, tracheobronchial tree injury, myocardial injuries, diaphragmatic tear, esophageal tear, and lung contusions. In a pre-hospital care setup, you have to stick to the ABCD of trauma and ship these patients as soon as possible to a tertiary care setup. I don't want to drag too much to this, and I would like to invite Dr. Ritu to take up from here. And at the end of this session, if you have any queries, please feel free to post your messages, and we'll be happy to answer your queries. Thank you. Thank you.
Good evening, everybody. I am Dr. Ritu Sabharwal, Associate Consultant at Max Specialty Hospital. Today, I am taking up the third lecture in the trauma series and will talk about blunt chest trauma, its salient features, and medical management. So, let's get started, and hopefully, this will be of some value in your clinical practice. Good evening, everybody. Myself, Dr. Ritu Sabharwal. I am an Associate Consultant at Max Specialty Hospital. Today, I am taking up the third lecture in this trauma series and will talk about blunt chest trauma, its salient features, and medical management. So let's get started, and hopefully this will be of some value in your clinical practice. As we all know, trauma continues to be a major public health problem worldwide as it is associated with high morbidity and mortality in both developed and developing countries, with approximately 5.8 million deaths worldwide. Trauma has also been reported to be the leading cause of death, hospitalization, and long term disability in the first 4 decades of life. Thoracic trauma comprises 20 to 25% of all traumas worldwide and constitutes the third most common cause of death after abdominal injuries and head trauma in polytrauma patients. Blunt thoracic injuries are more common than penetrating injuries, with most frequent causes being motor vehicle accidents, falls, and crush injuries. Trimodal distribution of trauma deaths. There are three peaks uh, from seconds to minutes. The first peak of death occurs within few seconds to minutes after injury, virtually inevitable, and very little can be done for these patients. The second peak occurs between a few minutes and an hour after injury. Here, this peak death distribution can be reduced by prompt initial care in the pre-hospital phase, by early hospital resuscitation, and by prompt and competitive definitive care. This period has been labeled as the golden hour. Management at this time will affect the third peak of the death. The third peak occurs several days or weeks after the initial injury. Immediate deaths are due to myocardial injury or major vessel injuries like rupture of the aorta. Early deaths are due to tension and pneumothorax, tamponade, flail segments, and hemothorax. 40% are due to airway and 30% due to blood loss. Many of these deaths can be prevented with prompt diagnosis and treatment. Less than 10% of the blunt chest injury require operative intervention, like thoracoscopy or thoracotomy. It means that 90% of the blunt chest injuries are conservative and are treated by technical procedures within the capability of clinicians. Assessment and treatment of thoracic trauma patients include preparation at pre-hospital and and hospital area, triage of the patients depending on the mechanism of injury, depending on the physiological parameters of the patients. Then comes primary survey and resuscitation and adjuncts to primary survey. Then consideration of need for the patient to transfer from one facility to the other, secondary survey, adjuncts to the secondary survey, then continued post resuscitation monitoring and re evaluation, and finally the definitive care. Preparation at pre hospital phase emphasis on airway management, control of external bleeding, and immobilization of patient. Hospital phase require advanced planning, resuscitation area should be available, airway equipment should be ready and checked, warm fluids should be available, and team should be informed. Primary survey has two goals. One is promptly identify the life threats, and second, provide immediate stabilization. Primary survey requires simultaneous assessment and treatment. There are 5 points to the primary survey. A is airway and cervical spine protection. So we have to watch for airway obstruction like laryngeal injuries, posterior dislocation of the clavicular head, which causes upper airway obstruction. B is for breathing and ventilation. Here we have to look for the entities which cause ventilatory problems and compromises to the patient who receives blunt chest trauma, like tension pneumothorax, open pneumothorax, flail chest, pulmonary contusion, and massive hemothorax. C is for circulation with hemorrhage control. Here in blunt trauma, we have to focus in circulation part for massive hemothorax and cardiac tamponade. D is disability and neurological status. E is exposure and environment control, prevent hypothermia to the trauma patient. The assessment of airway can be done in 10 seconds. Just talk to the patient, ask how does this trauma happen, and if your patient is able to talk and revert back properly, it means that your patient's airway is patent, his ventilation is not very much compromised, and his perfusion is fine. If your patient is unable to talk, so then watch for, is your patient is an altered sensorium? Is your patient agitated? Is your patient obtunded? Is he using the accessory muscles? Is he tachypneic? Tachypnea is the early sign of hypoxemia. Is my patient unconscious, GCS less than 8? It means his airway is compromised. Cyanosis is the late sign of hypoxemia. Listen to the abnormal breathing like snoring, gurgling, stridor, hoarseness of voice, or subcutaneous emphysema. These are all signs of acute airway obstruction. Hoarseness of voice and subcutaneous emphysema, these are the signs of laryngeal trauma. Airway threats, if you see that your patient has injuries over the face and neck, there is a swelling, hematoma, edema, because all these things can compress airway and compromise the airway. If there is a bleeding, nasopharyngeal bleeding, it can cause threat to aspiration. If you have crepitals, hoarseness over the neck area, such as tracheal or laryngeal injury. Higher spine injuries is threat to the airway. If a patient who has received burns or who has met with the explosion near him, then he's the candidate. He may get edema, which leads to the airway compromise. He may have inhalation injury, which cause pulmonary injuries. Management of the airways, age-appropriate positioning of the head into a neutral position. If you hear the gurgling sounds, gentle suction of the airway to remove blood, vomit, or secretions. Application of high flow oxygen. Jaw thrust, avoid head tilt or chin lift in trauma patients. These patients may have stable cervical injury. On doing this maneuver, head tilt, chin lift, you may progress it to unstable cervical injuries. Use of an oropharyngeal airway if tolerated. Use of nasopharyngeal airway if there is no basal skull fracture. Intubation by an experienced operator, and always keep a plan B, because if in case there's a failed intubation, you have the plan B to go as for a surgical airway. The cervical spine should be protected by manual inline stabilization, followed by a rapid application of a properly fitted heart collar. Assessment of breathing. You have to see how your patient is breathing. You look for, is he breathing fast, or is he breathing his breathing is shallow? Is he in respiratory distress? Is there any obvious injury to the chest, like external wounds or bubbles coming out of the chest tube, a chest wound, bruising over the chest, any seat belt marks, which will give you clue to the injury to the internal organs. Chest movement, is the patient's movement, chest movement is symmetrical, or it is a paradoxical movement, which will give you a clue to a flail chest. If one side of the chest is moving and the other side is not moving, there is a hypoxemia, there's a decreased air entry, the patient is having hypotension, then you can think of tension pneumothorax. Listen to the breath sounds. It will also tell you, is it a hemothorax? Is it a pericardial tamponade? Um, is it a tension pneumothorax or a hemothorax? Is it pilot failure? So it will give you the clue regarding what needs to be done for the ventilation. Feel for the pulse. Feel for the crepitus. Check the, palpate your chest. Palpate for, is there any subcutaneous emphysema? Is there any crepitus over clavicle or chest wall tenderness, which will give you clue of rib fractures, clavicle fractures, sternal fractures. And monitor oxygen saturation. It will give you the idea of ventilation. It is the early indicator using the pulse oximeter. Assessment of circulation can be done first visually. Look at the patient. What is his conscious level? What is the color of the skin? If his color of the skin is pink, or his color of the skin is gray, is he cyanosed? It will give you the status of the hemodynamic status of the patient. Feel for the pulse. You better feel for the central pulses like femoral pulse, carotid pulse, and check bilaterally. Check the quality, check the rate, check the volume. If the check the regularity of the regularity of the pulse. Regularity of the pulse will tell you regular, full volume, normal rate, will tell you about the perfusion. Then patient may have normal perfusion, or if patient is having irregular pulse, it may tell you about the cardiac injury. Measure the blood pressure and check for the capillary refill time. Monitor pulse and BP for reassessment. Any intervention if you have done first and then recheck, it will tell you that whether the patient has improved or deteriorated. Identify the potential source of internal hemorrhage. Circulatory hemorrhagic shock, obstructive shock, neurogenic shock, these are circulatory life threats. Hypotension and trauma considered to be hemorrhagic shock until proven otherwise. Tension pneumothorax and cardiac tamponade are the examples of obstructive shock, and in if a patient is having tension pneumothorax or cardiac tamponade, these patients deteriorate very fast. So we have to decompress the chest cavity and take care it with the needle decompression, with IV fluids, with oxygen. Neurogenic shock happens when there is a spinal injury above the level T6. The patient will have shock, hypotension, but extremities will be warm. He may have bradycardia. So we have to treat this emergency with IV fluids, start inotropic support, and other definitive care. Management of circulation. First is control of external bleeding with direct pressure. Ensure adequate IV access with two large bore cannulas, 16 or 18 gauge. If you are unable to put IV access, put IO access. Obtain samples for HB, blood grouping and cross matching. Give form fluids, NS or RL. Blood products should be started early in the trauma patients. Prevent hypothermia. Emergent treatment based on underlying injuries like hemothorax. So we will go for the definitive treatment like restoration of the blood volume, decompression of the chest cavity, thoracotomy, cardiac tamponade, patient with unstable hemodynamics. We will use ultrasound guided pericardiocentesis. In pelvic fractures, we'll put pelvic binders, and in hemodynamically unstable patients, we'll take the patient to OR, use external fixators. Tension pneumothorax. Tension pneumothorax is life-threatening condition caused by a pleural cavity which acts as a one-way valve. As a result, the air can enter the pleural space during inspiration, but is unable to escape during expiration. The accumulated air in the pleural space compresses the ipsilateral lungs, blood vessels, and other structures of the chest cavity to the opposite side. The mediastinal shift compromise of ventilation perfusion and kinking of the major vessels results in decrease in return to the heart. This leads to hypoperfusion and hypoxemia, which is lethal for the patient. These patients will have tachypnea, severe dyspnea, JVP is raised, hypoperfusion, decreased in air entry, hyporesonance on the affected side. However, in noisy ED, it is difficult to differentiate hyperresonance. Pre-hospital management includes ABC with C spine stabilization as needed. If patient use basic airway maneuvers and adjuncts if the patient's airway reflexes are present, or supraglottic device placement is not possible until assisted tract replacement is performed. Administer oxygen to correct hypoxia. Start IV fluids with large bore cannula in both arms to treat hypotension. Perform only chest decompression in a patient with suspected tension pneumothorax if there is hemodynamic instability or severe respiratory compromise. The use of needle decompression followed by the chest drain via thoracostomy in patients who are breathing spontaneously. Observe patient after chest compressions for signs of recurrence of the tension pneumothorax. It is very important. What we do is we do one intervention and we do not reassess the patient. So after every intervention, we have to reassess the patient, whether our patient has improved or our patient has not improved or our patient has deteriorated. Depending on that, our next action will depend on. So kindly reassess your patients every time you have done your procedure. Although the injuries typically can't be fixed in the pre-hospital setting, the patient can have supportive treatment provided that will support lost function. With any severe trauma patients, minimize seeing time and perform intervention en route to ED. In trauma patients, perform needle decompression of the affected side of the tension pneumothorax while preparing for the thoracostomy. Use 14 gauge cannula or the larger catheter at the upper border of the fifth rib, just anterior to the mid-axillary line. Remove the stellate and listen for the rush of the air. Reassess the patient. Assess for improvement. Open pneumothorax. There is a free communication between the atmosphere and the pleural cavity through a chest wall wound. Air tend to follow the path of least resistance if opening in chest wall is 2/3 of the diameter of the trachea or the greater. The entry of the air with each respiratory cycle through chest wall will result in progressive collapse of the ipsilateral lung. Spontaneously breathing patient has inability to generate negative intrapleural pressure on the affected side, results in progressive lung collapse on this side, leading to impaired ventilation. These patients will have dyspnea, sudden sharp pain, subcutaneous emphysema, decreased lung sounds on the affected area, red bubbles coming out through the wound on exhalation. So during pre-hospital care, if we see the chest open if we are suspecting open pneumothorax, we have to start the patient on high flow oxygen, apply occlusive dressing. Occlusive material has to be non-breathable material like plastic paper, or if you are unable to find plastic paper, if you have an aluminium foil, you can use that too. So whole idea is to prevent the air to enter through the wound during inspiration and allow the air to leave the pleural cavity during expiration. If we covered this occlusive dressing from all four sides, there is a possibility of developing a tension pneumothorax. So ensure the occlusive dressing is secured only on 3 sides and treat pneumothorax with placement of chest tube through intact skin. Cardiac tamponade. Blunt injuries can cause pericardium to fill with blood from heart, great vessels, or pericardial vessels. Even small amount of blood can restrict cardiac activity and refill and decrease in cardiac output. Such patients will have symptoms like chest pain, pre-syncope, dyspnea, orthopnea. On physical examination, classical presentation of cardiac tamponade can be muffled heart sounds, hypotension, and distended neck veins. It is also known as Beck's triad. It is also a left side tension pneumothorax mimicker. In tension pneumothorax, you will get the hyperresonance on percussion and decreased air entry on the affected side. But in cardiac tamponade, you will have bilateral breath sounds. ECG shows sinus tachycardia, low voltage. You can find electrical alternates. X-ray of patients with cardiac tamponade may show enlarged cardiac silhouette, and bilateral lung parenchyma will be clear. FAST is the rapid and accurate method of imaging, 90 to 95% accurate for the presence of pericardial fluid. The supportive care to be initiated with volume repletion, rarely an anatropic support is needed. If mechanical ventilation required, then use low inspiratory pressure with the evidence of hemodynamic compromise. Pericardiocentesis, ultrasound guided, can be performed to relieve symptoms if patient is in hemodynamic compromise and FAST is positive. It is diagnostic as well as therapeutic, but not a definitive treatment. Definitive treatment is pericardiotomy. This here we see that subxiphoid view where all four chambers of the heart are visible, and you can see the pericardial effusion around it, and there is a collapse of right ventricle. Aortic injuries is one of the most time sensitive, life threatening condition. Mortality associated with traumatic injury is 30% in first 24 hours. There are no specific signs. Patient may have chest pain relating to back. There may be a difference in BP between a right and left arm. There may be a palpable pulsating mass. Patient usually present in hypotension. The signs of shock will be there. So if we should have a high index to rule out such conditions. The risk factors for this disease: a patient with trauma, with such symptoms, age more than 60, a patient was a front seat occupant, not wearing a seat belt, front or rear side motor vehicle crash, abrupt deceleration more than equal to 40 km per hour, crushing of the vehicle more than 40 centimeter, intrusion more than 15 centimeters. All these risk factors point towards the blunt injury, points towards the blunt injury. And if you encountered X-ray with a wide mediastinum, on supine chest X-ray, if it is more than 8 centimeters and upright, it is more than 6 centimeters, think of this entity. If you find the obscured, indistinct, enlarged aortic knob, then also it is suggestive of aortic injuries. You may find left apical cap, large left hemothorax, which it is not here. These are lungs are clear here. But if you have large left hemothorax with wide mediastinum, think of the aortic injury. There will be a displacement of trachea and displacement of esophagus to rightward. So diagnostic testing depends on the hemodynamic condition of the patient. If patient is not hemodynamically stable, patient is in shock. So such patients with high degree of index, fast positive, and we have a high suspicion of aortic injury, we need to take cardiothoracic surgeon in loop early and decide to take the patient to OR for the exploratory surgery to find out the rupture in aorta and repair accordingly. But if your patient is hemodynamically stable, then we can go for CT, and depending on the CT findings, we can choose the treatment modality and treat patient with ABC, with spine control as indicated, high flow oxygen, treatment for shock, and rapid transport to the hospital, and rapid investigations, and depending on the hemodynamic instability, whether we have to undergo investigations, and according to the investigations, treat the patient and admit the patient. Flail chest. Flail chest is when 3 or more ribs are broken in at least 2 places with loss of continuity with the remainder of the rib cage, causing the flail segment to move paradoxically. Like here in this picture, during inspiration, the flail segment is retracting in, and in expiration, the flail segment is bulging out, which leads to injury to the underlying tissues like lung contusion, um, pneumothorax, hemothorax. The signs of flail chest include pain in inspiration causing shallow breathing or reduced inspiratory effort, tenderness of the chest wall, palpable crepitus of displaced rib, deformity of the chest wall. So, depending on all these signs and symptoms, one must think of the flail chest and treat the patient accordingly. Start with the ABC with C spine control as indicated. Start with high flow oxygen. Monitor patient for signs of pneumothorax, tension pneumothorax. Use gloved hand as a splint till bulky dressing can be put on the patient. Contact hospital as soon as possible. You can use, if you do not have any dressing, you can tape a bag of D5 on area and tape it down till you reach the hospital. Analgesia is very important. Here we can give analgesic as soon as possible. Airway management include intubation are not obligatory for flail chest in the absence of respiratory failure. Intercostal nerve blocks can be used in the emergency. Paravertebral analgesia can be started if patient has contraindication to the epidural. We do not have to over hydrate this patient. We have to avoid overhydration of this patient. Surgical fixation can be done in flail chest. Massive hemothorax. Hemothorax is basically a collection of blood in the pleural cavity. Our pleural cavity can accommodate 2,500 to 3,000 ml. Patients with hemothorax will complain of chest pain, shortness of breath, diminished breath sounds, dullness to percussion, and the signs of shock like pallor, confusion, tachycardia, hypotension. The treatment involves high oxygen concentration, take care of the shock, IV fluids, blood monitoring, decompressing the chest cavity with the chest tube 28 to 32 French is inserted at fifth intercostal space anterior to the mid-axillary line. If there is rapid accumulation of more than 1500 ml of blood or more than one-third of the patient's blood volume in the chest cavity, then it is massive hemothorax and we have to treat this patient on urgent basis and have to take up for thoracotomy. Last but not least, Commotio cordis. Commotio cordis is a phenomenon in which a sudden blunt impact to the chest causes sudden death in the absence of cardiac damage. This can happen in sports such as baseball, softball, hockey pucks, a blow in the boxing. Cardiac arrest caused by the direct blow to the thorax during the repolarization period results of chest wall impact directly over the heart. And sudden loss of consciousness is due to compromised circulation due to cardiac arrhythmia, usually VF, ventricular fibrillation. The patients with commotio cordis require immediate high quality CPR and early defibrillation for the better survival. While the best results are obtained by following ACLS algorithm and the use of AED will also prove beneficial. Most of the chest trauma patients may also be suffering from polytrauma, hence the accompanying injuries should be examined carefully. History and physical examination should not be missed. Imaging methods should be used appropriately. Patients should be treated with rapid diagnosis and treatment. Management of trauma patients is a long-term and holistic approach, including pre-hospital management, emergency care, intensive care units, and post-injury period. Thank you, everybody, for your kind attention.